Thank you. So I'm just here to introduce Viviana. She's a respiratory physiology researcher from the University of British Columbia, and she's been with us for a few weeks. So we're interested in breathing pattern research here, and we've been benefiting from Viviana's experience and expertise and insight into this particular methodology, the esophageal balloon catheter, she will be showing a video, but just to reassure anybody who's not sort of seen it before, there are a number of people here who have participated in this procedure over the course of the past couple of weeks and are still here to tell the tale. So it's quite painless. She's has a particular expertise though in the sort of methodology, and particularly in the measurements that you can take from it and the insights that you can gain from the particular procedure. And that's what she's here to share today. And we've had a preview of this yesterday and it was absolutely fascinating. So I'm going to hand over to Viviana now, and I'm sure she'll read you through it.
Thank you, Sam, for that lovely introduction. Thank you to the IS team as well for having me. I've had such a great time being over here. Awesome. Oh, I have that.
Yeah.
All right. So today, this is a bit of an outline of what we'll go through. We'll start with looking at the respiratory muscles as well as the mechanics of breathing, followed by using the esophageal balloon, and then some of the applications. And at the end, what my research looks like right now at UBC. So skeletal muscles are usually thought of as locomotor muscles or limb muscles that are used to run, ski, cycle, or hike. But oftentimes we don't think of them as muscles that do these carefully coordinated contractions for us to breathe. But respiratory muscles are skeletal muscles, and we've had 63 of them documented with the role of breathing, which is about 20% of our human skeletal muscle system. But how do we measure what these muscles are doing? Well, we can look at muscle shortening as a change in volume that respiratory muscle does to a particular structure. So for example, a change in the rib cage volume or a change in the abdomen. You can look at velocity of shortening of this muscle based on the change in flow. So our inspiratory flow when we breathe in versus our expiratory flow when we breathe out. And lastly, how we measure force is a change in pressure, the change in pressure that the respiratory muscles generate during while they breathe. So throughout this presentation, we'll look at these three variables of volume, flow, and pressure, and how we use those to collect data on the respiratory muscles. So a bit of background on the left side, or on the right side, or I guess your left, and on this side we have our inspiration and expiration. So the main primary muscle for inspiration is our diaphragm. It's innervated by the phrenic nerve, and during quiet breathing, it only moves about 1 centimeter. There's two sections of it, the costal part and the pleural area. But during heavy exercise, that diaphragm can move up to 10 centimeters. So if you do a forced inspiration or forced expiration, that diaphragm will displace up to 10 centimeters. Another important muscle for inspiration is the external intercostals. They're going to help increase the volume of the thoracic cage. And then we have two accessory muscles as an example. There's sternocleidomastoids and the scalenes. Sorry, I realize I'm not showing on there.
That's right.
The sternocleidomastoids and the scalenes here. Those are accessory muscles, and we don't really use them at rest. But as we start to increase intensity of exercise and increase our ventilation, they become really important in lifting our ribs and our sternum. However, if you go on to the expiration side, usually at rest during quiet breathing, it's passive, because when you inspire, you're moving away your lung and chest wall elastic equilibrium away from its equilibrium, and at expiration, you're bringing it back towards it. However, when you start to exercise, expiration becomes an active process, and you end up using these muscles over here. So you have your rectus abdominis, your external and internal obliques, as well as your transverse abdominis, to really decrease the abdominal volumes. And then you also have these internal intercostals to help decrease the rib cage volume. So overall, you have an increase in thoracic volume with inspiration, and you have a decrease in thoracic volume with expiration. So here in this diagram, we have a lung inside a jar with a pressure pump and a spirometer to measure volume. And then what we do when we change it, we'll show you on the graph on the right, where your pressure along the x-axis and the volume change on the y. So with this pressure pump, if you decrease the pressure within it, subatmospheric, you'll see an increase in volume as the lung expands. So that's, sorry, I should really use that. So that's this curve here, the first one. So decreasing the pressure, you're increasing the volume because the lung is expanding. And then as you decrease back the pressure towards zero, or I guess increase it, you're bringing the volume back down. So if you look at this curve, you can see there it's non-linear, and that's because of a component called hysteresis, which is because the lungs' viscoelastic components and the surface tension cause this difference in inflation and deflation. But when you look at the actual respiratory system, you can't just look at the pressure volume relationship of the lung tissue. You also need to consider what the chest wall is doing. So in this graph, we have pressure on the x-axis and then volume as a percent of total lung capacity on the y. And then just understand that the pressure is zero in the middle here with negative and then positive. The first line we'll go through is the pressure volume relationship of the lung here. You can see that the lung tissue is at equilibrium at about 20% of their total lung capacity. And that's why our lungs tend to want to recoil inwards all the time. The other line that we'll look at is, and that's at point B. The other line we'll look at is the pressure volume relationship of the chest wall, which is this gray line here. And it's at equilibrium at about 70% of TLC. And that's why our chest wall always wants to be expanded outwards. But these two relationships work together, and we have our pressure volume relationship of our total respiratory system, which is this green line. And at this point here, at point 1, this is functional residual capacity, also known as FRC. And that is when our chest wall tendency to want to spring out is balanced by the lung elastic recoil wanting to recoil in. And that's where we usually end our normal breath out. So if you're breathing quietly and you take an expiration and you want to stop, that's where you are at FRC. So your muscles are going to have to work with or against these pressure volume relationships of the chest wall as well as the lung. So at FRC, we're at 1 and we're at equilibrium. But let's say we increase our volume up to about 70% TLC. These arrows are representing what the respiratory muscles have to work against. So here, the respiratory muscles are going to work against the inward recoil of the lung elasticity, but so they're trying to push outwards to create this volume. But because they're in line with the equilibrium of the chest wall, they don't have to worry about what the forces of the chest wall at this point. But if we increase up to 0.3 here, now we're away from both the equilibriums of the chest and the lung. So the inspiratory muscles now have to work against both of them. Now, if we decrease our volume towards residual volume, our muscles are going to have to work to maintain a positive pressure as our chest wall tendency wants to go outwards. So on top of the elastic forces, we also have to think about the airway and tissue resistance. So tissue resistance doesn't take as big as a component as our airway resistance unless you have a disease. So we're really going to focus on the airway resistance. So resistance can be calculated by the viscosity, or is proportional by the viscosity and the length, and inversely proportional by the radius to the 4th power. So radius becomes a really important factor when you're looking at resistance for flow through a tube. So here, if you look at the first graph here in A, you can see the trachea, and then it starts to branch out. And this is the airways slowly branching out into more and more generations. As they branch out, these airways get smaller and smaller and smaller. And if you look at the second part, you have our airway generation from 0 to 25, and then S stands for cross-sectional area. So as you increase the airway generation, you see a greater and greater cross-sectional area. And you would think that last airway generation, because their diameter is so small, that's probably where the greatest resistance is. But it's actually the opposite, where you see on the last panel, we have the resistance on the y-axis instead, and airway generation on the x. The resistance is the highest at the first generations and drops down when you get to the smaller parts of the airway tree. And this is because you have a greater cross-sectional area. So, oh wait. So the method that we use the method used to look at these differences the respiratory muscles are doing is using an esophageal balloon catheter. So here on the left side, you have a picture of an esophageal balloon catheter. In the middle is an animation where the esophageal balloon catheter gets inserted through the nose down to the esophagus and into the stomach. It has two balloons, one that sits in the esophagus and one that sits in the gastric with EMG coils in between. And so it's really important that diaphragm is sitting between the two balloons. Here I have a video. So here I'm inserting an esophageal balloon catheter into one of our participants. I'm asking them to take sips and swallows as they have a catheter placed in them because we want their glottis to open to let the balloon in. So we have them slowly slipping and swallowing and we're feeding it in. I sped this up by 2 times, so it takes about 2 times the time for it to come for the placement to occur. And so the esophageal balloon will measure esophageal pressure. The gastric balloon will measure the pressure in the stomach. And our EMG coils will measure the electromyography or EMG of the diaphragm. So why we measure esophageal pressure, you can see that from the picture on the right here. This is a transverse plane cut through the lung, and the red dot is where you place the esophageal balloon in the esophagus. You can see how close the proximity is to the pleural pressure right here. The pleural pressure, yeah, the proximity of pleural pressure. So we use esophageal pressure as a surrogate for pleural pressure. On the left here is an example of what the esophageal pressure trace looks like. So you have esophageal pressure here on the Y, and this first part here is what the pressure swings look like at rest. This one right here is a big inspiration, and then the positive one is a big expiration. In the middle here is at 60% max intensity, and so you have you can see that these esophageal pressure swings are becoming more frequent and also larger. In this last section right here, this is at 100% max intensity. So now you can see how much more frequent these esophageal pressure swings occur, as well as how much larger they become. The other pressure we get is gastric pressure. And what's really great with getting both of these is now we can look at diaphragmatic pressure, which is an index of how much pressure that diaphragm is creating. So if you look at this picture here, the difference between esophageal and gastric is the pressure the diaphragm will be creating. So the last measure you can get from this balloon is EMG. So in between those two balloons, you have 10 coils. The first one is a ground, and then the last 9 here create 5 pairs of EMG electrodes. And it's really important that we have 5 instead of 2, because as I was saying, the diaphragm can move up to 10 centimeters within the chest wall cavity. And so it's important that we can collect EMG activity no matter where it is within the cavity. So this is an example of what the EMG activity looks like during exercise. You have EMG activity on the y-axis here with 60 to 80 to 100% of peak ventilation, and you can see that the EMG activity increases with an increase in ventilation. So as you start to exercise, you want to be able to maintain your blood gas homeostasis, and you do this by increasing your ventilation, right? But increasing your ventilation comes with a mechanical cost to breathing. And we usually look at mechanical cost or work as force times distance. But because we use a change in pressure as force and a change in volume as our distance, we can calculate work of breathing based on that. And with those 2 components that we spoke about earlier, we have a resistive component from the airways, and we also have a viscoelastic component from those pressure volume relationships. So there's 2 components to work of breathing: resistive, which is the work done in overcoming the resistance to turbulent flow, as well as viscoelastic, which is the work done in overcoming the resistance offered by lung tissue to deformation. So this is how we calculate your mechanical cost of work of breathing. So this is a pressure volume loop. You have volume on the x-axis,
and esophageal pressure on the Y. EILV stands for end inspiratory lung volume, so at the top of your inspiration. And end expiratory lung volume, EILV stands for end expiratory lung volume, which is at the end of your expiration. When you plot those on your pressure volume loop, you get this line here, and this slope is your compliance, which is the change in volume over the change in pressure. You then take the iso pressure of EELV across, and you take an iso volume of end inspiratory lung volume up to make this right angle triangle. So now we have 3 sections within our pressure volume curve. The first section here is the inspiratory resistive work that the respiratory muscles have to overcome. We have our inspiratory elastic work, and then we have our total expiratory work at the top. So here we're able to discern between elastic and resistive on the inspiratory side, but here we put total expiratory work in one section. So here's the graph here, and we know how we're getting our esophageal pressure, but how are we getting our volume? So there's 2 ways. One is you can just integrate flow from what you get from your flow trace. Another way is you can use a motion capture system where it looks at the change in shape of the abdominal and rib cage wall using reflective markers. So you have 89 to 90 reflective markers put onto the chest wall, and you can make different compartments. So in this example, they have 2 compartments. The first one is blue here, which is our rib cage compartment. And then we have abdominal compartment in green here. Now, if you look at the bottom, the left side is their cycling modality, and on the right side is our running modality. The first panels are volume over time, then you have esophageal pressure over time and gastric pressure over time. So we'll focus on the first section here of volume. The black trace is the volume changes we're getting from the motion capture system. And the red one is what we're getting through the flow integration. And you can see that they match quite well, whether it's during cycling or during running. Another way to measure your work of breathing, or at least calculate it, is using modified Campbell diagrams. So it's very similar to what we just saw with the pressure volume loop, but now the axes are flipped. So you can see that esophageal pressure is on the x-axis and volume is on the y-axis. You can pinpoint where your inspiration is here, and then you expire on this side. So you take a composite average of your pressure volume loops and plot those. You then find your end inspiratory lung volume, so the top of your breath, and end expiratory lung volume at the bottom of your breath. Very similar to the other one where you will find the slope between those 2, and that's your lung compliance. But we also have our chest wall compliance, which you can calculate with an equation and then plot it based on your functional residual capacity, right? That's where you're at a normal breath out, where those the lung and chest wall are at their equilibrium. So you can see here, there's 4 sections. So we have our inspiratory resistive in this section, our inspiratory elastic, and then our expiratory resistive and expiratory elastic. So we're able to now discern between in our expiratory work, what is elastic and what is resistive. So does this work of breathing differ based on sex? So in this study, they did an incremental exercise test with instrumented esophageal balloon catheter. We have minute ventilation on the x-axis, as well as work of breathing in joules per minute on the y-axis. And you can see about after 50 to 60 liters a minute, women have a greater work of breathing than men. And just to note that this line did get extrapolated over to 200 liters a minute, so they would be equal, but this line originally wasn't there up to that point. So they wondered, why was the work of breathing higher? Well, you can look at it based on those components that we went through. So we have male on the left and female on the right. And just visually, you can see that the female pressure volume loops are much larger than the ones in the male. Now, these 2 participants had comparable ventilations at 100 liters a minute, a comparable tidal volume of 2.2, and breathing frequency of 50 breaths per minute. And you can see visually one's larger than the other, and that's correct because the total work of breathing is almost double in this female. And why is that? Well, we can see it's because of the inspiratory resistive sides and the inspiratory, the resistive expiratory side as well. You see those two are much larger, whereas the viscoelastics are very, very comparable. So to understand why the resistive part of breathing is larger in females, you have to come back to this idea of dysynapsis, which comes dis from unequal and anaplexy from growth. And it's this idea that you can have disproportionate growth within two parts of an organ. So in our example, we're using airways as well as lung tissue. And so to measure this, we need to find a variable that's sensitive to airway size and a variable sensitive to lung size. So what we use is Vmax 50, which is the flow rate at 50% of your vital capacity. And you use vital capacity as your sensitivity to lung size. Now we're dividing out the this variable, which is your lung elastic recoil at 50% of your vital capacity, because your expiratory flow rates depend on airway size, but also it can also depend on your elasticity of your lungs. So we divide that out so we can really narrow down just what airway size is looking at. And with this, Dr. Mead found that fully mature lungs of men appear to have airways that are approximately 17% larger in diameter than are the airways of women. So with this concept in mind, one of my lab mates, their doctoral research was looking at differences in airway size using optical coherence tomography. So here they came into an incremental exercise test. They had an esophageal balloon instrumented to look at the total work of breathing, but then also divided into its components of resistive and elastic. They then went to the hospital. You can see here they're semi-sedated. And we put this probe, which is 508 microns, around a plastic sheath, which is 900 microns. This goes into the biopsy port of a bronchoscope, and we slowly feed, it through until it gets wedged into the airways. And once it's wedged in the airways, we have a motor system on it. And so it slowly pulls back. And as it pulls back, this probe has a camera on it, and it's videotaping in a circle as it gets pulled back. So an image, a snapshot of what the video looks like, is here. And with that, we can calculate the luminal area, which is our luminal area. And we did that with the fourth to eighth generations of the lung. When you associate the luminal area with work of breathing, you can see here our airway generations from 4 to 8 on the x-axis, and luminal area is on the y-axis. The females are in the white dots, where the males are in the black dots. You can see in generation 4 through 6, the luminal area is larger in males compared to females, but it's also good to appreciate that there is some overlap. And so this difference in luminal area was associated with our resistive component of work of breathing. So you can see at the top here, the total work of breathing is larger in females than males, and it's really explained because of that resistive component, because the viscoelastic point are very similar in females and males. And that is because with resistance, when we change that diameter, a large factor is that radius, because it's the fourth power to the fourth power. So how about aging? Well, a lot of things happen as you age. You have a decrease, a lot of your systems start to deteriorate. But the main ones that I want to focus on here with your mechanical work of breathing is with aging, you have a decrease in chest wall compliance as well as an increase in the lung tissue compliance. So your lungs become floppy. So in this study, they had younger and older females and males do an incremental exercise test with these esophageal balloon catheters placed. And they compared them at their minute ventilation in liters per minute to their work of breathing. So here we can see very similar relationship. The blue line is the younger females, whereas the red line are the younger males. And now if we plot the older individuals, we see the same relationship with the younger participants, but it's shifted upwards. So with aging, there's a greater work of breathing, but because of that increase in elastic work of breathing. So we looked at how we can look at the mechanical cost of breathing, but what about the oxygen cost of breathing? So In this study, the participants came in, they did a day one, they did an incremental exercise test with esophageal balloon catheter. They came in another day, they wore the same clothes, they sat on the same bike here, and they mimicked their ventilation that they did during exercise. And how are they able to mimic it? Well, it's because they looked at this screen here. They had a pressure volume loop to follow and a flow volume loop also. So they were mimicking what their ventilation looked like during the incremental exercise test. And how well did they mimic it? Well, you can see the first top panel here is their pressure volume loops during exercise. The bottom ones are their pressure volume loops as they were mimicking what their exercise ventilation looked like while seated on that bike. And you can see from 45% all the way to 100 on both of them. And you can see that these loops look very similar in size and shape. So they were able to mimic quite well what their ventilation looked like. When you plot it for males versus females with ventilation on the x-axis and VO2-RM as their VO2 for the respiratory muscles, you can see females have a higher oxygen cost of breathing compared to males. But overall, the VO2, the respiratory muscles take about 9 to 15% of full body VO2, which is a large portion. So a bit of a summary, we can use these esophageal balloon catheters to measure esophageal pressure as well as gastric pressure. These changes in pressure are used to calculate our mechanical work of breathing. And when we exercise, we increase this ventilation to maintain our homeostasis, but it obviously comes with this mechanical cost. And at absolute ventilation, the work of breathing is going to differ based on sex and age. And these mechanical work of breathing comes as well with an oxygen cost to breathe, which also differs based on sex. So the last variable that you can get from these balloons is the EMG of the diaphragm. So usually what they used to do is they used to put the electrode pairs on the outside on the skin. That's not a great way because the diaphragm isn't right there. It's more, and it also moves. So here in this study, they looked at EMG of the diaphragm using that esophageal balloon catheter, but they also looked at the EMG with surface electrodes of the scalenes and the sternocleidomastoids, because remember, as we exercise, they become more and more important to our ventilation. So here's an example of what it looks like between the muscles. So we have EMG on the first section for the diaphragm, then the scalenes and the sternocleidomastoids with an increase in work rate. And you can see that this EMG activity increases with increasing work rate. Another way you can apply EMG or collecting EMG of the diaphragm is with changing or manipulating the work of breathing. So you can use a proportional assist ventilator, also known as a PAV, to reduce the mechanical work of breathing. And so that means the respiratory muscles don't have to work as hard. And then we have our panels here. So this is a participant before they're on the PAV while they're normally exercising. You can see their flow is up here. This is their esophageal swings or esophageal pressure swings, their diaphragmatic pressure swings, and their EMG. Once they go on the proportional assist ventilator, so it's aiding them to breathe, you can see that these esophageal pressure swings decrease. You can also see the pressure of the diaphragm is generating also decreases. And visually, you can see that these EMG activity bursts are lower. So you can use this to manipulate how much the work of breathing is in a participant. So what I'm looking at currently in my PhD is this phenomenon called respiratory muscle metaboreflex. So when you have high diaphragmatic fatiguing diaphragmatic contractions of the diaphragm, but as well as other respiratory muscles, you'll have an increase in metabolites within the muscles, and that's going to activate our group 4 phrenic afferents. This is going to induce a reflex where we see an increase in sympathetic vasoconstriction activity within those limb muscles that are working. So this reflex has been characterized in females, males, young and old by using a procedure that isolates respiratory muscles. They sit, they listen to a metronome that tells them when to inspire and expire, and they're breathing on a mouthpiece. And this mouthpiece has a weight on it. So they have to be able to lift the weight to bring the inspiration in. And so they're following how much pressure they're generating, and they have to hit that goal. So when you look at a young female versus a young male, so the first section here, and you have mean arterial pressure on the y-axis, females right here have a decreased or an attenuated metaboreflex compared to young males. But when you look at an older female and older male, that sex difference is no longer present and they have a higher reflex compared to younger, their younger counterparts. But can we train this reflex? Can we lower or attenuate it? So in this study, they had 2 training groups, one that was a sham and one that actually used inspiratory muscle training for 5 weeks to hopefully train the metaboreflex. The black dot, or the first panels, are mean arterial pressure, and the bottom ones are heart rate. You have from minute 1, 2, and 3 up until failure. And you can see in the train group that after training, the white dots, there's an attenuated response to the respiratory muscle metaboreflex. So what I'm interested in looking at is, can we use inspiratory muscle training in females and older adults and see the similar effects? I also want to look at, does this inspiratory muscle training change the EMG activity of the diaphragm and the mechanics of breathing? And I also want to see if after 5 weeks of detraining post-IMT, how much of the changes remain. So that's my presentation. I want to thank everyone that has helped me at UBC as well as this university, and happy Valentine's Day.